Good morning. Wanted to thank all who have organized this gathering for including me. I have a presentation set that I'm going to change up as I advance, because a lot of what we've been talking to is kind of repetitive at this early stage. I'm going to spend a lot of my time describing what we have done at the Center of Excellence in Chagas disease, and stress particular things that I think we need to focus on. Before we start, can I get an idea of those who are here in the audience, who performs clinical activities? MDs, NPs, nursing, so very few. So I take it that you haven't seen firsthand the complications of this disease. It's kind of, we're intellectualizing it and we're talking about it, but why is this so important? I'm a cardiologist. I am not infectious disease. I am not public health. I am not global health. I'm a cardiologist. And Chagas, in particular in the US, we have most of our immigrants come from Mexico and Central America, and the Chagas that's endemic in the US is of the same strain. So we see cardiac complications of this disease that are devastating. It is a significant reason why people develop heart failure. And it's not just heart failure. Heart failure in the US is the most expensive condition to have. Chagas cardiomyopathy is even worse than the routine cardiomyopathies that we have. It causes terrible dilatation of the heart, where the heart becomes a bag. You develop profound heart failure where you can't breathe. And it causes terrible malignant ventricular arrhythmias, i.e. cardiac arrest. And it's not of one type of ventricular arrhythmia. It is so erratic and it's hard to control. So ultimately, our goal is to screen early before any cardiac manifestations start up. Because once they start up, you're already behind the ball. You're kind of too late, and at that point, we pray that we can control the disease and delay the progression. So I just wanted to start with that so you get an idea of why this is so important and why we're really trying to advance the treatment, the diagnosis, the screening, treatment of Chagas, because we will have and can have a huge impact. From my perspective, Chagas disease is a great model for preventive medicine, because if we do appropriate screening and diagnosing early and treating, we can then have a huge impact on who progresses to get the complications. So I just wanted to start with that so we're all on the same page as to why this is so important. I have no disclosures, and we all know that Chagas disease has received little attention. I started in Chagas in 2006. And at the time, I was one of the very few providers who was treating patients with Chagas, screening and treating patients. And my support at that time was, number one, Sue Montgomery at the CDC. I think most of the providers and and people involved in Chagas will recognize her incredible value to the Chagas community. And if I needed help, I had to go to people, experts in South America. Now I am very happy to say that our network has broadened, and throughout the US, we have multiple centers that are dealing with Chagas. So our awareness is gradually increasing and our numbers are gradually growing, but we have a long ways to go. Chagas, as you've all heard, is a disease of the poor. In our country, predominantly, they're not only poor, but many of them are here and they're undocumented. So there's a whole bunch of barriers that exist as to why they don't even come forward to get tested. And we don't really know the burden of disease here. We know, we have estimates that it's roughly maybe around 350-ish thousand, but that's probably excluding the undocumented population, which is significant. And a lot of this has been shown, but I also want to point out, if we focus our attention just on 4 states, in the US, I think we could have a huge impact because that's where a lot of our immigrants reside. And yes, there is endemic disease here in the US, autochthonous cases, but we have no idea what those numbers are. And Paula is making a lot of efforts to start screening in different communities to try to assess that. You always hear about young people who are healthy athletes who have primary cardiac event and cardiac arrest, and some die, some don't, and there's a question mark. Most of these people are also outdoorsy and athletic. I think every one of those patients should be tested for Chagas, but we're not there, where there is no awareness or very little awareness. And that's what we really need to improve, not only on a provider's perspective, but for those who are or may be at risk. The ultimate goals, I think in the US, we need to focus on several groups. We know that mothers who have Chagas transmit or can transmit Chagas to their babies. We also know that if we treat those, if we diagnose those women before they become mothers, that we block congenital transmission 100%, which is critical, right? That's a population we should target because our resources are limited. We can't, every medical officer, chief medical officer I've spoken to says we don't have the funding to test everyone who walks through the door. So I think we really need to kind of narrow down the groups, and that's, I think, what we're pushing for, our network in general. So pediatric population is really important because the younger you treat, the better the cure rate. So we have women, we have children. Also, we know that with the immigrant population, if they have lower than a high school education, they're at risk, higher risk. We know if they have an awareness of Chagas disease, that puts them at a higher risk. And we know that if they lived in thatched roofs, adobe housing, mud-packed housing, that puts them at an increased risk. So I think we need to kind of tailor our screening processes because ultimately, especially in the beginning, we're not able to test and screen everyone. We're not even close to being there yet, but even let's hope for the best of all possible worlds. We'll never get to a point, I don't think, where anyone who walks through the door that will have the resources to test, unless we can get really cheap and inexpensive and accurate testing, which hopefully we will improve on those, because that's one of our big barriers. This is what we do at the Center of Excellence. It's pretty straightforward. We've kind of been doing the same thing in terms of our approach. We have a process where we essentially look at the risks. If there's a risk, we've been screening. If they're positive, then we have to get a confirmatory diagnosis, which we all do through the CDC currently, but the CDC can't, as our numbers grow and our screening increases, the CDC can't be the main entity that does confirmatory testing. So we have to come up with modalities to do confirmatory testing. And again, that comes back to better testing modalities. Once they're confirmed, then we start the treatment. And we've come a long way. Initially, when I started, everything, all the meds had to come through the CDC. And there are two medications. Again, I think Colin mentioned they were developed 50, 60 years ago. Nifurtimox, which is what you had taken initially, right? Has a lot of side effects. And if someone doesn't have the side effect from the medication, that means they're not taking it. It's impossible to sail through without significant side effects, as Myra attested to. The other medication, and that's a 3-month course. The other one is called benznidazole. It's currently a 2-month course, and DNDi is doing trials to see if we can shorten the duration of the treatment. But again, significant side effects with that. Younger populations also tolerate the treatment better, which is another reason why we should diagnose when they're younger, aside from the better cure rate. And we are very aggressive with our treatment of Chagas. As a cardiologist, we go through pretty extremes, and I don't know, Myra, if I have your permission. She has done very, very well, but as she expressed, she has complications of the disease. And with Myra, we not only treated with nifurtimox initially, we then got approval. I made calls to see what to do. She was progressing in front of our eyes, which now we know probably is too late to stop completely, but we wanted to delay the progression of the disease. So we treated her with benznidazole also. She's the only patient I've had where we've used both agents in her. And since this is all anecdotal, but since we have, she's been stable and she hasn't progressed further, which we're all thrilled about. And I'm not saying this is what we should be doing at all, but I'm saying this is our desperation with this disease. We're quite attached to this young lady, and we don't want to see it progress. So when you get to the point of you're watching someone worsen in front of you, and the data is really not there in terms of what we can do next, you kind of reach for the stars. And I'm happy to say that our doing this, if that's the reason, we don't even know, right? But it's stabilized her. And we've done a lot of tests, and I just want to go through what our center has done in terms of prevalence. When we first started, we looked at our cardiomyopathy population, and lo and behold, 19% of the Latin American immigrants that we tested ended up having Chagas disease, which is huge. We looked at our EKG abnormalities and tested those with from Latin America, and roughly 5% had Chagas. Again, very, very high prevalence. So we just kept checking all of the different conditions, arrhythmias, pacemakers, and all of our patient population with cardiac involvement in the Latin American population had a high prevalence. We did a very large, so what does this mean? We decided to look at the general community. And we've did screening programs where we went into the community at least twice a month, offered free medical care, testing, screening. And this is the breakdown, and it kind of points to populations that are high risk of Chagas. The general prevalence was over 1%, which again is pretty significant. But when you break it down in our population, in our testing, El Salvadorians had the highest prevalence. So if you're from El Salvador, as Myra is, there's a higher chance that you have acquired Chagas. So again, if we're going to fine tune and focus in on who should be tested and who shouldn't, I think if someone from El Salvador walks through that door, they should be tested because they have a higher prevalence. Also, a couple other areas, regions in Mexico were very, very high. So Oaxaca and Zacatecas. So, and I already mentioned the high school education is important, their knowledge base, and their living conditions. And usually those who have acquired Chagas, we test all family members because they've lived in the same environment and there is congenital Chagas. And among family members, it was almost 7.5% prevalence. So significant numbers. And I'm just bringing this up to make everyone aware. And I think Collins really discussed a lot of the barriers that are there that we need to overcome. From my perspective, number 1 through number 10 is awareness. How do we increase awareness? Because if our providers don't have the awareness, Myra's story gets repeated over and over and over again. I have an email that I received this morning from someone like Myra who can't find it, who's tested positive, can't find anyone to care for them. We need to do better. We need to get to a better place. And the only way we can do that is by people being aware, right? Providers need to know that this is a significant disease in this country that needs to be part of their differential diagnosis. In particular, if they're a Latin American immigrant. Again, we don't know what we're dealing with from autochthonous cases in the US, but in certain regions of the South, also probably very, very significant, as we're already showing in Texas. And that being said, we've gone through what we need to do with better testing, better screening, better treatment modalities. One of the companies made a release today, Cafera, that they just got FDA approval for their testing, diagnostic testing. I haven't seen their specificity and sensitivity of the test yet, but it's a 2-tiered testing system that will give you confirmation also, which is what we need. We need a rapid assay test with confirmatory testing that we can do at bedside, just like what we do with HIV now. So those are just, some of my thoughts, some of our evidence, some of our goals, and I just wanted to start this off again to express why this is so important. This is not an esoteric, exotic disease. It causes malignant, awful disease that you wouldn't want any loved one to have, and people die. And that's that. Thank you for your attention.